Up next, Daryl Nacarelli is joined by Dr. Eric Bates, professor of internal medicine at the University of Michigan Medical School in Ann Arbor, Michigan. They cover bivalirudin or heparin. Is the war over?
Eric, welcome to ACCEL.
Thank you.
So, Eric, this dates back for a long time, so maybe you could give us a little history of the initial data with bivalirudin and how the drug was used and what started the whole controversy.
Yes, it's not a new drug. In fact, the first major paper was published in 1995 by John Biddle comparing bivalirudin with unfractionated heparin as an option for anticoagulation therapy during PCI. And that study actually showed a little bit of benefit for ischemic outcomes, and it showed a major benefit with lower bleeding risk, partly because the heparin comparator was administered at a very high dose. But back then, we were worried mostly about efficacy endpoints. And in fact, the study was felt to be disappointing by the sponsors, and they stopped development of the drug.
So after that initial data, how did things change? Because obviously the drug had a second life.
Yes, a couple of interesting people with experience in Big Pharma decided to start their own company, got control of the drug, figured out how to produce it at 1/10 the price, if I remember correctly, went back to the original data, changed some of the definitions to more current standards that we embrace now with how to define myocardial infarction and which clinical endpoints are relevant. And when they redid the data, the study actually showed some benefit on the ischemic side. And that gathered enough funding where they actually started up a robust clinical trial program, which now numbers probably 20 randomized clinical trials of bivalirudin versus other anticoagulant strategies in patients undergoing PCI and patients with non-ST segment elevation myocardial infarction and patients with STEMI.
Great. So obviously a drug that initially was studied in the early 80s, a lot has happened in the last few decades, and we went from bare metal stents to drug-eluting stents. We went from different doses of antiplatelet agents and 2B3A inhibitors. And what we're doing today is a lot different than what we were doing 5 years ago, no less, 25 years ago. So how has the data stood up over these trials, with those changes in technology and changes of concomitant drugs or doses?
I think it's important to remember that when the drug was being developed, we were doing balloon angioplasty without stent implantation. We were giving very long duration heparin therapy up to a day after the procedure. And we were using glycoprotein 2B3A inhibitors because we didn't have stents to prevent acute closure, and they did seem to be beneficial, but they increased bleeding risk. So the reason we probably have a controversy now is because practice has evolved so much. We've decreased the dose of heparin dramatically in the PCI laboratory. We now have stents that prevent acute closure for the most part, so we don't have to give prolonged infusions of heparin or glycoprotein 2B3A inhibitors. The stents are better, so the stent thrombosis rate has gone down. And some people have embraced radial artery access, which also decreases bleeding. So the challenge for bivalirudin over, 2 decades or more is that the comparator has changed. And practice is different. And now there's some that find not much added benefit with bivalirudin, a more expensive drug than with unfractionated heparin because of these other developments that have made the PCI procedure safer.
So you mentioned the magic word cost, right? Because if we talk about that historical march through interventions, and it wasn't that long ago, the cost for the glycoprotein 2,3-BAs were quite high initially, but that was part of what it took. And now we're in a different paradigm. So is there any data, or is cost a big factor? Is it a small factor? I mean, heparin's pretty cheap right now, but bivalirudin's not outrageously expensive.
Well, it depends on how you count your dollars. Again, I'd have to go back and look it up, but I think when bivalirudin came out, it was like $330 for a dose. And now the brand name is up to like $950. So as they got positive trial results and built their market, the price somehow increased. This is generically available at about $550 a bottle. But if you live where I live and where you live, we have patients over 100 kilograms, and then you might need 2 bottles. So it might cost you $1,000 for generic bivalirudin versus heparin, which is probably $2. So cost is important as we move forward and worry about our budgets now in ways we didn't before.
Well, of course, the cost of whatever we've done over the years of intervention has to do with the results. So if you could spend $500, get a better result than you would without spending that, and the patients don't have a repeat ischemic event, they're not rehospitalized, you don't have to do a second intervention, then that's money well spent. So
that's an interesting point you raise, because actually, as the bivalirudin cost has doubled or tripled over time, the drug-eluting stent cost has actually been halved, even though we're getting much better results with new scaffolds and new polymers and new drugs that are being eluted.
So if we look at this, and again, there's a lot of these drugs we've used for decades, we continue to use them with good results, and they're part of our armamentarium, but the armamentarium continues to change. So I guess in today, where are we? Like, what is bivalirudin's role, in most intervention labs, do you think, today?
So if you compare bivalirudin versus the combination of unfractionated heparin and a glycoprotein 2B3A inhibitor, bivalirudin gives pretty equivalent results, although there's a slightly increased risk of stent thrombosis in the first 24 hours, but there is a reduction in bleeding. So conversely, if you do not use glycoprotein 2B3A inhibitors, if you use more potent P2Y12 inhibitors, prasugrel or ticagrelor, if you use radial artery access, then the comparator changes. And there's some people doing meta-analyses that have argued that if you just look at the radial artery subset, there's equivalency between bival and unfractionated heparin. If you look at the low-dose heparin subset, there's equivalence. It's only when you add on the glycoprotein 2B3 inhibitor and compare one antithrombotic versus two antithrombotics that you see the balance between efficacy and safety swing toward bivalirudin. So there's some laboratories still embracing bivalirudin, and there's some laboratories that have gone over to radial artery access and lower doses of antithrombotic therapy. And we have that debate. I'm not sure there's a clear-cut answer on who wins. Both sides can marshal evidence to support their position.
I think the key thing, maybe in summarizing, is that the data for this drug has been quite good for decades. There's other drugs also that are part of that armamentarium that are either equal, or we could argue where they are. But it's a changing dynamic, so keeping up on this and the changes in technology with the new drug-eluting stents, we do more radials at our site too, might change which drug you use, and the next patient you might use a different drug because it's a whole different experiment.
You're an electrician and I'm a plumber.
Right.
The good news is the procedure has gotten so much safer than in the early days, right. And it's almost hard to do randomized trials now because the event rates are so low. And it's become an outpatient procedure,
right?
Which also means you want to use lower levels of antithrombotic therapy to improve safety in that first 24 hours.
Well, Eric, I really appreciate you sharing this information with us today at ACCEL, and thank you very much for joining us.
Thank you.